afternoon to all the consultants, general practitioners. Welcome back. This is again our first session of CME on dog QT this year. We are very happy to have Dr. IRSHATH IBRAHIM. Before we start off with the topic today, we are going to have a brief introduction about the consultant. Dr. IRSHATH IBRAHIM Ali graduated with Doctor of Medicine from University Science Malaysia and further obtained his postgraduate medical diploma in the UK. He further obtained an advanced master in dermatology from University Kebangsaan Malaysia, and he's also recently obtained a diploma in aesthetic medicine. He is currently practicing as consultant dermatologist in the dermatology department in Sultanah Bahia Hospital, Alostar, and he is also a visiting dermatologist at KMI Taman Desa Medical Center since November last year. He is the member of Dermatology Society Malaysia, and he also a former honorary lecturer for AIMS University Malaysia and College University in Senia, Sungai Petani. Today, the topic is Staphylococcal and Streptococcal Cutaneous infections. Doctors, the floor is yours.
All right, thank you very much, Yuli, for that kind introduction. Okay, so I'll begin to share my slide. All right, so good afternoon, everyone. So today's topic, I would like to share with you the common dermatological cutaneous bacterial infections, namely Staphylococcal and Streptococcal infections. So there's just too much to cover, so I'll just cover on what we commonly come across, which is the non-necrotizing infections of the dermis and the subcutaneous fat, such as cellulitis and erysipelas. These two topics I'll go into in detail, whereas the superficial cutaneous infections and pyoderma, I will browse through a few common staphylococcal, streptococcal infections, and I'll also talk about the bacterial microbiome in the human skin. So first off, cellulitis. Cellulitis is a non-necrotizing infection affecting the dermis and the subcutaneous fat. So because our lymphatics is located in the dermis, and therefore the lymphatics also can become inflamed. So the common pathogens are group A beta hemolytic streptococci and Staphylococcus aureus. Most of the cases are due to group A beta hemolytic streptococci, but other groups such as group B, C, and G can also be implicated. The Staphylococcus aureus is that causes cellulitis can also be associated with carbuncles, abscesses, and furuncles. So if you come across a patient with furuncles or abscesses and also has associated cellulitis, think of Staph aureus. And sometimes you can also get a mix of gram-positive cocci and gram-negative aerobes and anaerobes, often implicated in cellulitis, especially in diabetic patients and patients with decubitus ulcers. So the incidence is about 199 per 100,000 person per year, with nearly equal rates in male and female. And the age increases about 3.7% for each year, of age of about 43.8% for each 10-year increment. Now, these statistics are mainly in the United States. So the portal of entry for cellulitis, it's mucocutaneous. So example, any cutaneous ulcer or any site of trauma is apparent in 30 to 82% of patients. Now, hematogenous spread, although possible, is quite rare. And most of the time, the lower extremities are affected, the lower limbs, 70 to 80% of cases. But in children, it often affects the head and neck. And the organisms for children are a bit different. Pneumococci, Neisseria meningitidis group B, and Haemophilus influenza type B. So what are the risk factors of cellulitis? Obesity, previous cellulitis, like patients with one attack of the lower extremity, have an annual recurrence rate of about 8 to 20% in the subsequent 1 to 3 years, usually in the same area. Other risk factors include alcoholism, IVDU, peripheral vascular disease, lymphedema, venous insufficiency, skin surface that has been disrupted due to ulceration, trauma or eczema, tinea pedis or interdigital intertrigo, which is fissuring and scaling and maceration in the toe web spaces, previous history of saphenous venectomy, and edema due to any cause like chronic liver disease, chronic kidney disease, or congestive heart failure. So the clinical presentation, we can go back to the classic findings of inflammation, which was once summarized by the Roman writer Celsus in who lived from 30 to 38 AD. So erythema, edema, heat, and pain or tenderness. This is a brief, this is the characteristics of the skin in cellulitis. So you will get redness, erythema, warmth or hot. The surface is edematous and is raised above the surrounding unaffected skin. You might get pudy orange or dimpled appearance. Bullae can be present, either you get clear bullae or hemorrhagic blisters. Cutaneous hemorrhage often present. This is manifested as either petechiae, ecchymosis, or hemorrhagic bullae. Now the borders in cellulitis is irregular and skip areas are common. This means that there are some areas that are unaffected. We'll show you later in that picture. Lymphangitis, lymphadenitis, pruritus, and scaling is usually absent unless from underlying disease like eczema. So this is the typical clinical picture of cellulitis. The spreading and initially it will be blanchable erythema, which arises because of increase in blood flow through the dilated cutaneous vessels. So this will create a warmth in the affected area. The redness is typically well demarcated, but irregular border and offers sparse portion of the skin. So you can see some areas are spared. So these are called skip lesions. So the inflamed and edematous area will rise above the adjacent unaffected cutaneous surface to create a plaque that pits on pressure. So if you apply pressure, you can create pits. And the superficial edema may eliminate the fine wrinkling. So because the skin is too edematous and distended, you don't typically see the fine wrinkling. So this causes the skin surface to be smooth, taut, and shiny. But when the edema diminishes with leg elevation, or once we start treating the patient with antibiotics, the normal fine cutaneous wrinkles can become more prominent. And then the skin, which was once distended, becomes more lax after being stretched beyond its customary dimension. So this appearance of the cutaneous surface can often resemble pudy orange or an orange peel. So this is some pictures of the first picture is bullous cellulitis. So you can see there's extensive soft tissue infection of the lower extremity. This particular case is due to group A streptococcal infection. And then here you can see blisters and edema. Whereas here in this picture, you can see multiple areas of necrotic crusting and focal purulence due to streptococcal cellulitis. So this is also cellulitis with blister formation. You can see erythema, edema, and large blister. This blister is clear, whereas in this picture, figure 4, is cellulitis with hemorrhagic blister. And there's also edema, dimpling, erythema, extensive cutaneous hemorrhage as manifested as ecchymosis and hemorrhagic blister. And here you can see streaks of erythema, tenderness, representing inflamed lymphatics. You can see that the lymphatics are inflamed and is tracking upwards here over the medial aspect of the thigh. So these red lines can be continuous or interrupted, and sometimes skip areas I mentioned earlier are present between the proximal edge of cellulitis and the distal end of the lymphangitis. The draining inguinal lymph nodes can become enlarged, tender, warm, and red. So systemic features are also some commonly associated with cellulitis. Patients can present with fever, chills, rigor, tachycardia, hypotension, confusion, and blood picture will show leukocytosis, predominantly elevated neutrophil. So over the past decade, there have been numerous reports of widespread emergence of MRSA. So for subcutaneous abscesses, community-acquired MRSA must be considered the causative pathogen until a microbiological diagnosis is obtained. So in this patient, this is a 20-year-old college student who experienced the left first toe trauma, chest trauma on the left first toe, and subsequently developed a abscess, which was MRSA soft tissue infection. And this patient required IND. So if you just bring your attention to this small box over here, these are some of the medications that we can use for community-acquired MRSA. This is from MOH and National Antibiotic Guidelines. So you can you can start the patient on 300 milligrams of clindamycin or 450 milligrams of oral clindamycin 8 hourly, or doxycycline 100 milligrams BD, or Bactrim 1 tablet twice a day. Duration of antibiotic can range between 1 week to 10 days. Now, cellulitis sometimes may look like other diseases. So this is known as the mimickers of cellulitis or pseudocellulitis. So there are a lot of mimickers. I'll just go through a few common ones that we may come across in our clinical practice. Like take this for example, it looks like cellulitis, but this is actually a configured erythema. That means configured referring to its pattern, very annular. So this is erythema migrans, which is also a pseudocellulitis. You can see an erythematous plaque here. So erythema migrans is commonly associated with Lyme disease, which is due to the organism Borrelia burgdorferi. And then a few other mimickers of cellulitis: acute eczema. Eczema in acute stage, it tends to present with erythema, scaling, ill-defined erythematous patch or plaque with scaling, and it can have oozing or serous discharge as well. And this is stasis eczema, quite often due to chronic venous insufficiency affecting the lower limb. So you can see dryness, scaling, and erythema. And this is contact dermatitis, which is typically an eczema rash, but due to something that the patient might be allergic to. It may give the false impression of cellulitis. And this is acute lipodermatosclerosis. So acute lipodermatosclerosis is actually the sequelae of chronic venous insufficiency. So if you have chronic venous insufficiency secondary to saphinovenous obstruction, or the saphinovenous valves are dysfunctional, then you can develop lipodermatosclerosis, whereby the subcutaneous tissue becomes thickened and fibrosed. So it usually occurs in the shin area and the medial aspect of the ankles, like over here. So you get this erythematous plaque that typically looks like cellulitis, but is actually due to lipodermatosclerosis, which is secondary to chronic venous insufficiency. So if it's chronic, then the skin lesions become more thicker. You get more thickened subcutaneous tissue, becomes more fibrous, a more thickened appearance, and ultimately it can lead to an inverted champagne bottle appearance. Herpes zoster also might give the appearance of cellulitis, but the dermatomal distribution should differentiate herpes zoster in contrast to cellulitis. And small vessel vasculitis also gives a appearance of cellulitis. Lymphoedema and paniculitis, which can be associated with connective tissue disease or infiltrative diseases like TB or sarcoidosis. Paniculitis is usually an erythematous subcutaneous nodule, which is associated with pain. It's very tender. And this is carcinoma erysipeloid. In this case, it's due to adenocarcinoma of the breast. So what happens is that malignant cells will start to infiltrate the skin, and then it gives the appearance of this erythematous patch or thin plaque. It's not exclusive to adenocarcinoma of the breast. Other cancers like thyroid CA, lung CA, gastrointestinal malignancy can also be associated with carcinoma erysipeloid. So the complications of cellulitis can have acute GN because of the nephrotogenic strain of group A beta hemolytic streptococcus, lymphadenitis, subacute bacterial endocarditis, recurrences related to disrupted lymphatic damage. So when the lymphatic system gets damaged, ultimately it can lead to lymphoedema and recurrent cellulitis, and The other complication is septicemia. So these are some of the lab investigations that we can carry out. Routine blood tests like full blood count, renal profile, liver enzymes, muscle enzymes to screen for muscle involvement or infection. Imaging that might be necessary is mainly to detect the presence of gas that can suggest necrotizing soft tissue infection. So plain film will be sufficient. And ultrasound, if you want to rule out other causes like swelling due to deep vein thrombosis, or it can detect any underlying collection or abscess. A CT or an MRI role is to evaluate for any necrotizing soft tissue infections, like soft tissue gas, deep fascia thickening, or associated deep tissue abscesses. And if the patient is admitted, then a blood culture would be warranted. Or you can also send a swab CNS or pus CNS from the wound or ulcers. Needle aspiration from the blisters. Punch biopsy usually will not be necessary unless the diagnosis is in doubt. And cultures from the blisters, fluid-filled bullae, or culture of the drainage. So this for dermatologists, normally if dealing with skin biopsies, a skin biopsy in a patient with cellulitis is usually filled with lymphocytes and neutrophils in the dermis and the subcutaneous tissue. So these small cells you see here are neutrophils. You can see some are trilo, and you also have a few lymphocytes surrounding the dermis and the subcutaneous fat. So the treatment. So quite often we, of course, will the first thing to do with cellulitis is to start with an antibiotic, but quite often cellulitis is due to predisposing conditions like tinea pedis, for example. So always remember to check the web spaces of the toes, see whether there's any maceration, any evidence of interdigital intertrigo, because you might need to treat that in order to effectively treat the cellulitis. And then any trauma, any site of injury, or stasis dermatitis. Elevate the affected limb to promote gravity drainage of the edema and inflammatory components. Quite often, you can ask the patient to either do it at home, or if the patient is admitted, wet dressing with potassium permanganate. So usually we use diluted potassium permanganate, 1 in 10,000. So you can ask the patient to soak their legs, or you can ask the patient to soak a thin cloth and then place it on the seroexudative areas, the blister areas. The purpose of potassium permanganate, it functions as a astringent, and therefore it will help to dry up these areas. So once the area is dry, you can instruct the patient to stop the potassium permanganate wet dressing. It also has anti-inflammatory properties, potassium permanganate. NSAIDs can be also given, like ibuprofen, for example, 400 milligram every 6 hours for 5 days, along with the antimicrobial agent. So NSAIDs can help to significantly reduce or regress the cellulitis as opposed to antibiotics alone. Now, if the patient is not diabetic, if sugar control is not a problem, then oral prednisolone is the other option, 40 milligram daily for 7 days, plus the antibiotic of choice. So this combination therapy has been significantly more rapid cure, and earlier switch from IV to oral antibiotics is favored. Shorter duration of hospitalization, and corticosteroids can help to reduce lymphatic damage, which predisposes victims to further attacks. Because once the lymphatic is damaged, lymphoedema ensues, and this can predispose to recurrent attacks of cellulitis. So these are the national antibiotic guideline for cellulitis. So whether it's Staph aureus or Streptococcus pyogenes, you can start with cefalexin, 500 milligram 6 hourly. Alternatively, you can give cefroxim, 250 to 500 milligram BD, or augmentin, 6 to 5 TDS. Duration of antibiotics, I normally give 7 to 10 days. For moderate cellulitis, this would require admission, and we can give IV cloxacillin, which can cover both staph and strep, or IV cefazolin, 1 to 2 grams 8 hourly. For very severe infections, you can go for IV unicin, 3 grams 6 to 8 hourly, or even IV clindamycin 600 milligram 6 hourly. But once the cultures are available, de-escalate accordingly. And alternatively, IV tazocin 4.5 gram 6 to 8 hourly, with or without clindamycin. So in uncomplicated cases, 10-day course of oral antibiotic is appropriate with either cloxa, cefalexin, or clindamycin. Now, old school clinicians might have come across IV penicillin, 2 megaunit 6 hourly, plus IV cloxacillin, 500 milligrams 6 hourly. I used to use this regimen when I was a house officer, but studies have shown that there's no added benefit of treating lower limb cellulitis when combining these two antibiotics. This was reported by Lehman P. in 2005. So for diabetes and decubitus ulcers complicated by cellulitis, broad spectrum antibiotic is favored. Either you can give tazocin or if penicillin allergic, then you can go for metronidazole with ciprofloxacin. For MRSA cellulitis with abscess, MRSA, we think about clindamycin, Bactrim, or doxycycline. If the group A streptococcal infection is also present, then these agents can be combined with a beta-lactam antibiotic. Okay, prophylaxis. Now, the British Lymphocyte Society first-line recommendation, if the patient has had more than 2 episodes of cellulitis in a year, then they advocate starting the patient on oral penicillin B, 250 milligram BD. If the BMI is above 33, then 500 milligram BD for 1 year. And then lower the dose to 250 milligram daily for another 1 year. So lifelong antibiotic prophylaxis is indicated if cellulitis recurs after 2 years of prophylaxis. So I normally follow the British guidelines, but in comparison, the IDSA, Infectious Disease Society, recommends that prophylactic antibiotic therapy should continue as long as the factors for cellulitis recurrence is present or persists. So recurrences for IDSA is 3 to 4 times a year, despite efforts to alter predisposing conditions. So the options for IDSA is monthly IM benzathine penicillin, 1.2 megaunit, oral erythromycin, 250 milligram BD, or nasal mupirocin BD, 5 days in a month. That means every month you give for 5 days. So this is mainly to get rid of Staphylococcus aureus carriage, especially the nasal carriage. Okay, so what can we do for recurrent cellulitis? Manage the weight loss, treat underlying infections like tinea pedis, interdigital, intertrigo, treat underlying edema. So you need to investigate why is the patient having edema, whether it's cardiac related, liver related, or kidney related, and treat underlying leg stasis eczema if it's present. Okay, so I'll save all the questions for later. I'll go into erysipelas. The skin infection of the upper dermis and superficial lymphatics. So the difference between erysipelas and cellulitis is that erysipelas affects the upper dermis and the superficial lymphatics, whereas cellulitis affects the deeper dermis as well as the lymphatics. So erysipelas classically involves the face, but most of the time the predominant location is the lower extremities and the lower limbs. So classic findings are rapid expanding, well demarcated, as in contrast to cellulitis, it's a bit more ill-defined. So erysipelas is very well demarcated, shiny, erythematous, painful plaque, associated with swelling, and perifollicular edema, or pudy orange appearance. So the organisms are group A beta hemolytic streptococcus, but other groups are also possible like B, C, G, and F. These are the most common pathogens to cause erysipelas. And the majority of erysipelas is due to group A. And MSSA is also possible, MRSA is also possible, especially in high-risk populations. So the facial involvement looks like the butterfly pattern of lupus, lupus erythematosus, where it affects the malar distribution, the cheeks, and also the nasal bridge. So it can be associated with systemic symptoms like fever, malaise, chills, rigor, lethargy, And one unique finding of erysipelas is the involvement of the ear. Now, the ear does not contain any deep dermis tissue. So this is termed or coined as Williams ear sign, which is erysipelas involvement of the ear. So antibiotics for erysipelas, the common organism because it's Strep pyogenes. So you would be logical to give phenoxymethyl penicillin 500 milligram 6 hourly, or an amoxicillin 500 milligram 8 hourly. Cefalexin is the other option. Cefalexin can cover both staph and strep. Now, if severe, it requires admission, then sorry. So if severe requires admission, IV benzyl penicillin 2 to 4 mega units 4 to 6 hourly, or alternatively IV cefazolin 1 gram 8 hourly, or IV cefuroxime. MRSA, you would have to admit the patient for IV vancomycin. So the duration of antibiotics 7 days to 10 days. Okay, so other antibiotics, especially if systemic symptoms are present, IV ceftriaxone covers Streptococcus only. IV cefazolin can cover both strep and Staph aureus, and IV vancomycin recommended if MRSA is suspected. Okay, so now I go to superficial cutaneous infections and pyoderma. So before I do that, I will just trying to get rid of this. Okay. Okay, so the bacterial microbiome composition in the normal human skin, according to the anatomical position. So the normal human skin has plenty of commensal organisms, and Staphylococcus is one of them. So if you notice Staphylococcus, it's located a lot in the nares, 16%, the axilla, antecubital fossa, umbilicus, inguinal creases, interdigital web spaces of the toes and fingers, the gluteal cleft, popliteal fossa, plantar heel and toe web spaces. So if these are the areas that you would expect an infection of Staphylococcus to occur. Okay, so the Staphylococci is classified into two major groups: Coagulase negative, which is your Staphylococcus epidermidis, and Coagulase positive, which is your Staphylococcus aureus. Now, Staph epidermidis is the major commensal bacterium found in the surface of the human skin. So any individual can carry many transient and resident colonizing strains of Staph epidermidis. And it can cause infection, especially if the patient has implanted foreign materials, surgical implants, indwelling catheters, or in cases of immunosuppression. Staph aureus is the most common cause of superficial purulent skin infections. Now, at any given time, 30% of individuals are continuously colonized with Staph aureus, and occasional carriage is found in 60% of healthy individuals. So you can be healthy, but you can still carry Staph aureus. This represents a common source of infection and risk factor. Okay. So this is staphylococcal skin infections. So I've already gone through okay, so this is staphylococcal skin infection. So I've already gone through cellulitis and erysipelas. So now we'll go to the superficial infections. So the first one is impetigo. So there are two clinical patterns of impetigo, which is non-bullous and bullous. The non-bullous is 70% of the time is caused by Staph aureus, or it can also be caused by group A beta hemolytic streptococcal, or it can be in combination of both. It's more often seen in children, but also in adults. So this is impetigo. So you can see this erythema with honey colored crusting or golden colored crusting on the nose and also on the upper lip. So these are all the areas of Staph aureus carriage. And then over here, you can see superficial round to oval erosions with central thin crusting. And then this peripheral collarette. Peripheral collarette is all this scaling that you see on the periphery. This is collarette scale. So this is impetigo in the axilla. Sorry about that. So this is bullous impetigo caused by Staph aureus strains that express certain exfoliative toxins. So Staph aureus can express many toxins. So exfoliative toxin A and toxin B, it tends to cause blisters because it, the cells are adhered to one another, and it's adhered by desmoglein 1. This is like a bridging for the cell. So what the exfoliative toxin does, it damages the desmoglein 1, and therefore the cells become apart. They don't stick to one another. So this gives rise to blisters. So you can see here bullous impetigo, these two pictures. So in the nares, Staph aureus or non-bullous impetigo often presents with a transient papule or pustule, as seen in this picture. So patient might complain of itch, soreness, honey-colored crusted papules and plaques. So this is the area of the nasal carriage. So you can see erythema. There's a small pustule on the tip of the nose in an individual that has been colonized by Staph aureus. So an ecthyma is also caused by the same organisms, and ecthyma is actually an impetigo that has been untreated and then it evolves. So it extends deeper and penetrating the epidermis. That means it can penetrate the dermis already, presents with a punched out ulcer with dirty gray yellow hard crust and material that can be debrided. So sometimes you need to debride the material and do dressing for the ulcer. So this is Staph aureus ecthyma, multiple thick crusted ulcers on the leg of a patient with diabetes and renal failure. And this is a more severe form of ecthyma, ecthyma gangrenosum, which is due to Pseudomonas aeruginosa, which resembles Staphylococcal or Streptococcal ecthyma. So for these type of ecthymas, ecthyma gangrenosum, you need to debride the eschar, the necrotic patch, and then perform dressing over the area and cover with antibiotics that cover for Pseudomonas. Okay, so this is the antibiotic for localized impetigo, which is due to Staph aureus or strep pyogenes. So you can, if it's very localized, you can just get away with 2% fusidic acid. But if you want to treat, if it's an extensive, then you can give oral cloxacillin 500 mg to 1 gram, 6 hourly for 7 days, or oral cefalexin 250 to 500 mg, 6 hourly for 5 to 7 days. Now, generalized impetigo or ecthyma, cefalexin is a choice, or augmentin. Penicillin allergy, erythromycin, ethyl succinate, 800 mg BD is an option. Or if community acquired MRSA, clindamycin, 600 mg 8 hourly, or Bactrim, 1 tablet twice a day. Okay, so Yuli, are you there?
Yes, I'm here.
Do you see this bar on top here?
No, it's very clear.
It's very clear. Oh, okay,
yeah.
so it's just my screen. There's a bar on top here. Okay, never mind. All right, so next up is folliculitis, furuncle and carbuncle. All right, so folliculitis is divided into superficial and deep. Superficial meaning it only affects the follicular infundibulum over here. So you can see the inflammation is just localized to the hair follicle and the follicular infundibulum. There's deep folliculitis. The entire hair follicle is affected. You can see inflammatory cell infiltrates around the hair follicle. Furuncle is a more deeper form of inflammation. So you get a lot of inflammation of the hair follicle, and it already forms a fluctuant abscess on top here. Whereas a carbuncle will be a network of furuncles connected by sinus tract. So these are the difference between folliculitis, which can be superficial or deep, which often presents as a papule or pustule. Furuncle is already a fluctuant abscess, and a carbuncle is a network of furuncles. Okay, so this is how superficial folliculitis might look like in a patient with Staph aureus infection. You can see multiple pustules confined to the beard area. And this is Psychosis barbae, which is a deeper form of folliculitis, also due to Staph aureus infection. You can see it's formed crusting already. And this is Lupoid psychosis, which is folliculitis that already has resulted in scarring. Now these conditions here, although it looks like infection, is actually non-infectious and inflammatory follicular disorders that are more common in men of African descent. So this is known as pseudofolliculitis barbae. Why? It looks like folliculitis. Yeah, you can see papules and on the lower beard area, but it's actually due to the ingrowing hair, because the hair in black individuals, or due to their ethnicity, the hair shaft is curved. So when it grows back, it causes ingrowing hair, and this can result in pustules. However, Staph aureus infection must be ruled out. And over here is acne keloidalis nuchae, which is occurs in the nape of the neck, quite often affecting the way the hair is cut. The hair is cut too short, or if patients are very obese and they have a lot of skin fold around this area, they can develop acne keloidalis nuchae. It's not infectious, it's an inflammatory follicular disorder. And the last one is perifolliculitis capitis, which occurs on the scalp. So a furuncle. So a furuncle is a fluctuant abscess. This is a furuncle on the upper lip. Lesion looks nodular, and this is a necrotic plug covered with purulent crust. So you see all this honey-colored crust, most likely it's a Staph aureus infection. And then you can see several small pustules over this side. And this is multiple furuncles, also already forming abscesses on the buttocks in a patient with inflammatory bowel disease. Carbuncle lesion represents multiple confluent furuncles over the nape of the neck here, with a lot of draining pus and multiple openings. And this is a abscess. So this is a large painful abscess in the heel of a patient with diabetes who presented, however, the severe pain persisted, and X-ray showed that the patient had actually stepped on a broken off sewing needle. So because of sensory neuropathy, the patient was unaware that he had stepped on a needle. Okay, never mind. So necrotizing fasciitis, sometimes it's you can certain investigations might be helpful, like if you do an X-ray to see whether there's any gas. And then quite often it's very extensive, very necrotic, foul smelling, as opposed to bullous cellulitis. Bullous cellulitis, of course, you can get cutaneous hemorrhage, which I wanted to show you in my picture. So the cutaneous hemorrhage might give an appearance of NF, but you should be able to differentiate PTK, ecchymosis of cutaneous hemorrhage, or hemorrhagic blister. So what might be helpful, if in doubt, you can do an X-ray to see whether there's any gas. Other things that might be helpful is an ultrasound to see whether there's any collection. But clinically, you can see that necrotizing fasciitis is a more extensive form of infection, whereby there's swelling, there's distension, there's a lot of necrosis, and might be associated with foul smelling. That's NF. So the NF, you most likely you will need IV antibiotic therapy admission. So that is NF, and NF would warrant a referral to our orthopedic colleague for further intervention. So I just wanted to show you this picture again. Yeah, okay. So this is bullous necrotizing cellulitis. So you can see that there are blisters that are formed. There's edema, and then there's extensive soft tissue infection. But it's not foul smelling. It's not extensively necrotic. And the other picture I wanted to show you is this cutaneous hemorrhage.
Okay, now my doctor, just leave it because a lot of questions pertaining to the question will be good for you to show photo. Okay, the second question, is it safe to give creamy antibiotics, especially fusidine, near mucous membrane like nostril?
Ointment is preferred. But yeah, ointment is preferred. Usually near the nostril, I would give intranasal mupirocin ointment for Staphylococcus aureus carriage. So ointment is preferred. Okay. But there's no detrimental effect of giving cream. It's just that the preference is ointment. Quite often, I sometimes this is mainly for eczema patients. When you treat the patient for acute eczema, for example, you're given a course of prednisolone, you're given a course of antibiotic, and then still the patient comes back with a subacute, acute flare. So things that can help is intranasal mupirocin. You can give BD to TDS for 5 days. Ask them to do it for 3 months. And also a bleach bath or chlorhexidine bath. So if they have a bathtub at home, they can immerse themselves for about 20 minutes, 2 to 3 times a week. So I sometimes advise them to do this to get rid of Staphylococcus aureus carriage. So in impetigo, also is something we in skin infections also we can consider intranasal mupirocin.
Doctor, because we have a large group of the audience today are actually GP. So at what stage a primary care doctor we need to refer a patient with cellulitis to a secondary or tertiary care?
Right. When you come across a case with cellulitis, there are a lot of things you can pick up in primary care. Just look for underlying comorbidities that might have contributed to the cellulitis, like tinea pedis. You can treat the tinea pedis first with a course of oral antifungal. You can treat the cellulitis with a course of antibiotic, which we have gone through. And if you have potassium permanganate, either in powder form or solution, you can instruct the patient to use potassium permanganate to dry up any seropurulent discharge. So these are the things that you can do. But if it has failed, if all this has failed, then most likely you need to refer to tertiary care or to a dermatologist so that we can investigate further and see whether the patient requires an admission for IV antibiotics.
All right. There's a third question from Dr. Nadira. Hi, doctor. Is it okay to drain cellulitis blisters?
Drain cellulitis blisters. Okay, I don't often do this unless the blisters is very, very big. Then I might puncture it and just take out the blister and send for blister CNS. But once you put the potassium permanganate wet dressing, that means you dilute the potassium permanganate. It's purple, so you should dilute it until it's pink, and then you soak it with a gauze, and then you apply the wet gauze on the seropurulent areas and the blister areas. So this will help to dry up the area and also dry up the blister. So I normally recommend doing this. But if you want to, if the blisters are very, very big, and if it's difficult for them to wear their clothing or their garments, then yes, if it's very big, then I'll prick it and send the fluid for blister CNS.
All right. So okay. All right. So just now in your slide, you did mention about lipodermatosclerosis. This is due to venous insufficiency, right? What is the best treatment for these conditions?
Okay. You may have come across patients that present with something that looks like cellulitis, then you treat with antibiotics adequately, but they keep coming back, with what looks like a recurrent flare. You might be dealing with other conditions that mimic cellulitis. So lipodermatosclerosis is one of them. So for lipodermatosclerosis, you need to examine the leg thoroughly, see whether there's any underlying varicose veins, anything that might imply chronic venous insufficiency, which can lead to stasis eczema. So this patient, you will have to treat stasis eczema, for example. And then for varicose veins, you might need to start Deflon, which might help varicose veins, unless it's very, very extensively damaged, and then you have to refer to a surgeon. And then you can also advise the patient to elevate the leg whenever they are asleep to reduce the swelling. And if the chronic venous insufficiency that has already led to the lipodermatosclerosis, they will need to wear medical compression stocking, which will help to alleviate the swelling. So you can ask them to do these things. But lipodermatosclerosis, once it is chronic, it's very little can be done because the skin has already become thickened, fibrous, and subcutaneous fibrosis has already occurred. So it's very difficult to reverse this process. So you have to explain to the patient that these changes are most likely permanent. But there are other steps that that I mentioned earlier. We can help to alleviate or reduce the swelling.
Okay, all right. There's no more question from the floor, but the last question I would like to ask Doctor is that what is your advice to the primary care doctors? Because as you explained your PowerPoint presentation, it has so many different conditions due to strepto and staphylococcus. So if they do see one case in the clinicals in your clinics, so what would be the first thing they need to do? Like, do they need to run some blood tests, like what you say mentioning just now? Because in the facilities may not have X-rays, ultrasound. So, what is the primary that they could actually offer to the patients and what they should look for it?
Routine blood tests is, I mean, if you have it, then you can send a full blood count, CRP, then routine would be renal profile and liver function test also, which will be useful because if the patient has any fungal infection, then you might want to look at the liver as well to see whether there's any contraindication to start any antifungal therapy like oral itraconazole or oral terbinafine. So if you ask me if it is warranted to send a renal profile liver function test, yes, you can send, because infection can also compromise your renal and liver. So these are routine blood tests that can be that you all can do. X-ray, if you have it, if you suspect an extension, or maybe osteomyelitis or gas in the underneath the skin, then you can proceed. But it's not compulsory just the routine blood test will be sufficient. And the antibiotic of choice, you can always start cefalexin, which can cover both staph and strep, or cefuroxime. These are the antibiotic of choice that you could start. Manage on your own first, and if you see things are not improving, then you can refer the patient to the tertiary center.
Okay, doctor, there's one question popping. What are the do's and don'ts when this infection are detected in pregnant women?
Pregnant women, okay. So pregnant women, basically the antibiotic you might want to consult consult with ONG whether there's any contraindication to starting an antibiotic of choice. I know that some of my ONG counterparts, they are not fond of augmentin for I think it was something to do with the gut. I can't recall. But antibiotics that are safe in pregnancy is, if they have no allergies, erythromycin. You can start erythromycin, and as long as they don't have any allergies, I'll be more concerned if they don't have any allergies. If they have allergies, then I'll be more cautious starting antibiotic. And because the cellulitis is confined, to either the leg or the arm. So you can still apply astringents like potassium permanganate to dry up the mucopurulent discharge. So don'ts, if you ask me what are the don'ts, is basically the antibiotic. You just check with your ONG counterpart whether there's any contraindication if you want to start something. So augmentin is one of their antibiotics. Not to say no, they are not fond of augmentin. It necrotizing enterocolitis, I'm not mistaken, in the infant. So that's one of the association.
Okay, I think we have no more questions. Right. Thanks, doctors, for your precious time today. And so I think, okay, Dr. IRSHATH IBRAHIM is available in our hospitals. KMI Taman Desa is on Monday, Wednesday, and Thursday, 2 to 5 p.m. So based on his presentation, I think we all benefiting definitely, because there's so many conditions of the skin due to these two bacteria. So I think in primary care, yes, there are things that can be done, but there are things that beyond the facility sometimes, yeah. So yeah, he's available here. All right, thanks, doctor, for having this session today. I think we're going to see you all next month. We're going to have this in monthly basis. Thanks for having us today. Thanks, DocQuity team as well today. All right, thank you. Bye-bye.
Thank you.